gonna start a very important topic, which is basically another blood disorder, leukemia. Let's start. Bismillahirrahmanirrahim. So basically, leukemia is the neoplastic proliferation of the cells which form WBC within the marrow. So basically, there is an abnormal growth of the WBC within the marrow. Basically, either it is due to genetically or environmental factors. Okay, because it is again is a systematic disease. Leukemia is classified according to their origin, heterogenetic criteria, myelocytic and lymphocytic, and according to their clinical presentation, means it depends on the origin, and heterogenetic criteria means myelocytic, those immature cells that develop into the red blood cells or other cells, but lymphocytic cells are like B lymphocytes and T lymphocytes actually. So their classification is based on their origin, heterogenetic criteria, which is myelocytic and lymphocytic, and clinical presentation means three. It is on the basis of three types. Okay. Now there is acute and chronic. The acute has two types: acute lymphoblastic and acute myeloblastic leukemia. Means in acute and chronic, then acute is divided into two forms, which is lymphoblastic and myeloblastic. Chronic is basically a chronic lymphocytic leukemia is. Okay. Now, clinical features or oral manifestation is recorded to the 30 to 80% of patients within the leukemia, more than seen in acute rather than chronic form. Means they are seeing that the oral manifestation is more in acute form than in the chronic form. Mucosal is paler because there is again it is a blood disorder, decreased blood flow, petechiae, which is pinpoint, and enchymosis and bleeding actually. Oral ulceration, gingival enlargement, and tooth mobility can be seen in this. Delayed wound healing and laryngeal pain, cervical and submandibular lymphadenopathy. Very important question. If you can see in leukemia, which lymph nodes are basically affected? Cervical and submandibular lymph nodes are basically become pathogenic. Okay, bacterial, viral, and mycotic infections are common oral complications. The patient suffers from the bacterial and viral and mycotic infections. Okay, then poor oral hygiene may be a predispose the patient to develop oral lesion. Now first we have tell you about oral manifestation, which was paler oral mucosa, gingival enlargement, basically petechiae, enchymosis, bruising, bleeding, and many more. Now we come to systematic fever, chills, weakness, fatigue, and weight loss and headache. Skin is paler, bleeding bone pain. The bleeding bone pain, very important characteristic. There's a bleeding bone pain. And then you have the hepatosplenomegaly, means your spleen and liver is enlarged, and there is generalized lymphadenopathy they are saying. Diagnosis is confirmed by oral biopsy. You have to take the oral biopsy, you have to take the blood count, you will check for the full blood count, in which you will check for thrombocytopenia, for other diseases. Bone marrow, that either the bone marrow is suppressed or not. Biopsy again, and histochemical and immunological test, which is very important. Now differential diagnosis, you have studied what is neutropenia, basically abnormal basically decrease in neutrophils. Okay, agranulocytosis. Okay, aplastic anemia you have studied. Then thrombocytopenia purpura, Hodgkin lymphoma, non-Hodgkin lymphoma, gingival fibromatosis, and gingival enlargement due to drugs. Okay, basically. Now the treatment is basically high levels of oral hygiene. You have to do oral hygiene. Then you will prescribe the patient mouthwash, which is antiseptic, chlorhexidine, yeah, hydrogen peroxide, which is antifungal, antibacterial. All infections should be treated as possible. All regions usually regress during systematic treatment of leukemia. They are saying when you are treating leukemia, so the oral lesions basically reversible. They are reversible. Treatment must be carried by hematologist definitely. So you will prescribe the patient oral hygiene, mouth washes, and then it will be normal. Okay, so this is the pain. This is the two main things, and the treatment should be carried by the hematologist. Okay, systematic treatment or therapies is like topical application 0.1% of triamcinolone acetinoid oral base. They are saying you will give a topical, basically triamcinolone. Okay, then clobestrol gel or tacrolimus, which is 2 by 4 times daily 1%, and poidine iodine solution may be used. So you have to give in topical triamcinolone acetonide 0.1%, and clobestrol, and then tacrolimus basically daily, and 1% of poidine iodine. Okay, in systematic treatment you can include the blood transfusion, okay, red cells and platelets transfusion. Okay, then you can give granulocyte colony stimulating factor recombinant in erythropoietin administration, and chronic B lymphocyte leukemia oral chlorambucil is effective actually. Okay, now basically before we have discussed general treatment, that you give oral hygiene, basically instruction, chlorhexidine, okay, chlorhexidine mouthwash. Now they come to topical, in which you give the triamcinolone acetonide, and then clobestrol gel or tacrolimus, and 1% poidine. In systematic you have to give blood transfusion actually. Then you can give factors like granulocyte colony stimulating factor recombinant erythropoietic administration, and chronic B lymphocyte leukemia oral chlorambucil is effective in this. Okay, so basically for this, in chronic leukemia you can give the chlorambucil bucil. Now, IV oral fludarabine administration, highly effective fludarabine. Myelocytic for the myelocytic leukemia, hydroxyurea orally combined with the subcutaneous interferon alpha. Means if a patient is myelocytic leukemia, he is passing, you have to give hydroxyurea with subcutaneous interferon alpha. Then you can give imetanide you can give mesylate. Okay, now you can give tyrosine kinase inhibitor, excellent result. Remember, okay, myelocytic anemia for best, you can give tyrosine kinase inhibitor, which is best. Okay, now in acute leukemias, basically acute lymphatic leukemia is a combination of chemotherapy including corticosteroids. Means you have to give the corticosteroids and chemotherapy. Then vincristine and cyclophosphamide methotrexate. Then for future treatment, like again acute myelocytic leukemia, combination of biological agents with definite molecular targets, monoclonal antibodies, tyrosine kinase inhibitor, and retinoids. So basically you have read it about. So first I have told you what is leukemia. It is the abnormal increase of the WBC. Then we have told you about the classification. It is based on the origin. It is based on the basis of the heterogeneity criteria of the myelocytic and lymphocytic, and then on the clinical manifestation. Then I have told you about the oral lesions, that the oral mucosa is paler, bruising is there, petechiae is there, gingival enlargement is there basically. Then I have told you about the systematic, which is like fever, chills, headache, lymphadenopathy is present here. Then we have discussed about the DD's differential diagnosis. I have told you neutropenia is there, agranulocytosis is there, then thrombocytopenia purpura I have told you. Then we have talked about the treatments. Number one was the preventive treatment, like you can give oral hygiene instruction, chlorhexidine mouthwashes. Then you can give to the topical treatment, which is actually 1% triamcinolone acetonide you can give, or clobestrol. For systematic you have to give the blood transfusion. Okay, then we have also discussed some other treatments. Then we have discussed about acute leukemias. You can give chemotherapy with corticosteroids, etc.